お前はもう死んでいる。何？
Migraine is a benign, episodic syndrome of headache associated with certain features, such as sensitivity to light, sound, or movement. Nausea and vomiting often accompany the headache. It is a recurring syndrome of headache associated with other symptoms of neurologic dysfunction in varying admixtures. There are three approaches to migraine treatment. 1. Non-pharmacologic approach, such as the avoidance of patient-specific triggers. 2. Regulated lifestyle, healthy diet, regular exercise, regular sleep patterns, and avoidance of excess caffeine and alcohol. 3. Drug treatment of acute attacks, prophylaxis. So how do we assess it? We employ the Migraine Disability Assessment Score, or MIDAS. It is a set of questions to help measure the impact your headache has on your life. The questionnaire was based on 5 disability questions that focus on lost time in 3 domains. 1. School or work. 2. Household chores. And 3. Family, social, and leisure activities. The questionnaire has demonstrated reliability, with scores that are highly correlated about the severity of illness and the need for treatment. Patient education is an important aspect of migraine management. It is helpful for patients to understand that migraine is an inherited tendency to headache, and that it can be modified and controlled, but it cannot be eradicated. Except in some women on oral estrogens or contraceptives, migraine is not associated with serious or life-threatening illnesses. So what are the acute attack therapies for migraine? The mainstay of therapy is the judicious use of one or more of the many medicines that are effective in migraine. The table on the right shows the different drug classes used to treat for acute migraine. The selection of the optimal regimen for a given patient depends on a number of factors, the most important of which is the severity of the attack. Mild migraine attacks can usually be managed by oral agents. The average efficacy rate is 50 to 70%. Severe migraine, on the other hand, may require parenteral therapy. Most drugs effective in the treatment of migraine are members of one of the 3 major classes: non-steroidal anti-inflammatory drugs, triptan receptor agonist, and dopamine receptor antagonist. In general, adequate dose of whichever agent is chosen should be used as soon as possible after the onset of an attack. If symptoms return or have not abated, additional medications is required within 60 minutes. The initial dose should be increased for subsequent attacks or a different drug class tried as a first-line treatment. Since a standard approach for all patients is not possible, migraine therapy must be individualized. A therapeutic regimen may need to be constantly refined until one is identified that provides the patient with rapid, complete, consistent relief, and with minimal side effects. So let us now discuss the different drug classes that are used to treat migraine. First, we have non-steroidal anti-inflammatory drugs or NSAIDs. It is most effective when taken early in the migraine attack. For moderate or severe migraine attacks, its effectiveness is usually less than optimal. The combination of acetaminophen or paracetamol plus aspirin and caffeine is used to treat for mild to moderate migraine. The important side effects of NSAIDs are dyspepsia and gastrointestinal irritation. Second drug class would be your 5-HT1B or 1D receptor agonist, collectively termed as triptan receptor agonist. Stimulation of these receptors can stop an acute migraine attack. Routes of administration include oral, nasal, and parenteral. For the oral, we have non-selective and selective receptor agonist. For non-selective include ergotamine, dihydroergotamine. Ergotamine there appears to be a much higher incidence of nausea than with triptans, but less headache recurrence. We also have selective receptor agonist, the triptans, which is also available for the treatment of migraine. Monotherapy with selective oral 5-HT1B or 1D receptor agonist does not result in rapid, consistent, and complete relief of migraine in all patients. Triptans are generally not effective in migraine with aura unless given after the aura is completed and the headache initiated. Side effects are common, although often mild. It is contraindicated to patients with history of cardiovascular or cerebrovascular disease. For patients requiring a non-oral route of administration, nasal sprays can be alternative. In theory, nasal sprays might provide faster and more effective relief of migraine attack than oral formulations. Studies with a new inhalational formulation of dihydroergotamine indicate that its absorption problems can be overcome to produce rapid onset of action. Substantial blood levels are within 30 to 60 minutes. Parenteral is another route of administration in this class of drug. For rapid relief of migraine attack, we have dihydroergotamine and sumatriptan. The next class of drug would be your dopamine receptor antagonist, which comes in two forms, oral and parenteral. It is considered as adjunctive therapy in migraine. Drug absorption is impaired during migraine because of reduced gastrointestinal motility. When oral NSAIDs and or triptan agents fail, the addition of dopamine receptor antagonist should be considered to enhance gastric absorption. Dopamine receptor antagonists decrease nausea or vomiting and restore normal gastric motility. There are other options for acute migraine. We have oral, which is a combination of acetaminophen, dichlorphenazone, and isomethiptine. We also have parenteral, which is opioids, and neuromodulation, which is a single pulse transcranial magnetic stimulation or STMS. Next, acute attack medications can induce a state of refractory, daily or near daily headache called medication overuse headache. This condition is likely not a separate headache entity, but a reaction of the migraine patient's biology to a particular medicine. There are preventive treatments for migraine. Good candidates for preventive agents include patients with an increasing frequency of migraine attacks, with attacks that are either unresponsive or poorly responsive to agents. Preventive medication are considered in patients with 4 or more attacks in a month. The mechanism of action is unclear, and it seems likely that the brain sensitivity that underlies migraine is modified. It is usually on a low dose of a chosen treatment, then the dose is gradually increased up to a reasonable maximum to achieve clinical benefit. Treatments that have the capacity to stabilize migraine are listed in Table 422-6. Most treatments must be taken daily, usually a lag of between 2 and 12 weeks before an effect is seen. FDA approved for the preventive treatment of migraine include propranolol, timolol, sodium valproate, and topiramate. Other drugs that display preventive efficacy include amitriptyline, nortriptyline, flunarizine, phenelzine, and cyproheptadine. Phenelzine is a monoamine oxidase inhibitor reserved for only very recalcitrant cases. Methizigride is no longer manufactured. Once effective stabilization is achieved, continue for approximately 6 months and slowly tapered to assess the continued need. Many patients are able to discontinue medication and experience fewer and milder attacks for long periods. Okay, that's all for the treatment of migraine. Thank you for listening.